Thank you very much, and apologies for the minor IT glitch. So my name's Nick Barrett. I'm a consultant at Guy's and St Thomas's in central London, opposite Big Ben, so we're very easy to find. And I've been there for nearly a decade now, and I set up and continue to run the ECMO program, predominantly based about respiratory ECMO, but also cardiac and ECPR. I have no particular conflict. I think the most important thing when we're thinking about the role of ECMO in cardiac arrest is that it's not about ECMO. The most important thing in cardiac arrest remains your basic chain of survival. You've got to recognise arrest. You've got to have the person at home noticing that their relative has collapsed, or the nurse in the hospital noticing that the patient has collapsed. You've got to get early, high-quality CPR. Rapid onset, high quality, good depth. You have to get early defibrillation. Without the basics in place, thinking about ECMO is a bit of a waste of time, in all honesty. If you're not finding the patients till 2 hours into cardiac arrest, they've not had CPR. So it's only a tiny, tiny, tiny component, and probably only suitable for a very small number of patients. But it is the way things are currently going. Don't forget your basic algorithm, and we'll come back to this at the end. Unresponsive, CPR, shockable, non-shockable, go through the drill. Looking at the different pathways, looking at the different treatments that we have available, and thinking always about your treatable causes. This has to be the first line. Nonetheless, in 2015, the European Resuscitation Council suggested that ECPR, or ECMO-based CPR, extracorporeal CPR, is a reasonable therapy for select patients when conventional CPR has not worked, and where it can be implemented. And you'll notice it's a weak recommendation on very low quality evidence, and I would put it as very, very, very low quality evidence. And we'll go through what limited evidence there is, but it's mainly observational. Let's look first of all at out-of-hospital cardiac arrest. So out-of-hospital cardiac arrest has been looked at, and there are a number of studies in the literature looking at it. The most recent is the SAVE-J study, and I'll show you that in a second. But the outcomes overall, we've got 36% survival in one, but most usually it's somewhere between 5 and 10%. Certainly in the UK, survival from out-of-hospital cardiac arrest for all comers, with or without ECMO, is around 8%. And this is with ECMO. So 4 to 5, maybe up to 10%. One small study, 8 out of 22 patients had a neurologically favourable outcome at hospital discharge. In hospital is possibly a little bit better. Maybe 1 in 3, 1 in 4, 1 in 3 will survive neurologically intact. And again, this is a range of data which has been presented in a number of studies. There's been an attempt at a propensity match survival analysis looking at control groups, and this is all observational data with matched populations, so this is not randomized data. And you can see that you've potentially got a small signal of benefit in this meta-analysis towards favouring extracorporeal life support. However, you'll also notice that the numbers are tiny. For those of you engaged in cardiology trials, where you've got thousands upon thousands of patients, this is ridiculously small. Even by intensive care trials, it's very small. So we've got little numbers, but there is possibly a signal of benefit there. One of the most important things to look at is not just survival, however. It's neurologically intact survival. What's actually happening to our patients' brains? And what we want is a cerebral performance class of 1 or 2. 1 or 2 is back at home with assistance of varying sorts, clearly 2 more so than others. 3, 4 and 5 are progressively damaged all the way up to nursing home bound, unresponsive, persistent vegetative state. And just over half of patients if we look at an ECPR, have, in this particular group, of those who survived, half of survivors were cerebral performance class 1 or 2, and the rest were cerebral performance class 3, 4 or 5. One of the most recent studies has been the SAVE-J study, performed in Japan. And they looked at, again, it was a propensity-matched prospective observational study, so not randomized. They used multiple hospitals. They had not a bad group, so they had 260 in the ECPR group and just under 200 in the non-ECPR group, but not randomized, very much subject potentially to bias. But they found, both at 1 month and at 6 months, a relative improvement in neurologically intact survival, cerebral performance class 1 or 2, with 12% of the group, 11 to 12% in the ECPR group having a CPC 1 or 2 versus 1 to 2%. So significantly lower than the many observational studies even in the non-ECPR group, which has been interesting. If we look at this study, which came from Taiwan, at the 6-month mark, again, they found there was a difference. It was propensity matched, it was observational, it found, nonetheless, a neurologically intact survival at 6 months, which was maintained over 2 years. So, again, we're looking at around 15-20% neurologically intact survival from this group. And if we look at a recent meta-analysis coming earlier this year, we can say that there appears to be, on small numbers, and the SAVE-J study wasn't included in this, but there appears to be a benefit for patients in terms of neurologically intact survival, albeit the numbers are very, very small in both groups. And that does, of course, raise significant issues around resource allocation, and what do you do with patients who do not make a neurologically intact survival? There's been one randomized controlled trial, and it's worth thinking a little bit about this particular trial. So it was the CHEER study. It was performed in Australia by my good friend Vin Pellegrino and colleagues. And they looked at a group of patients who were relatively young, so adults, 18 to 65 years of age, had a primary cardiac etiology for cardiac arrest. They excluded everybody else. They only included you if you had a witnessed arrest with CPR within 10 minutes, followed by the initial rhythm when the ambulance turned up of ventricular fibrillation. And they looked at both in and out of hospital cardiac arrest. You had to go on to mechanical CPR. They were not interested otherwise. And if you met all the inclusion criteria, then a clinician stood at the end of the bed and said, yes, we'll put you in, or no, we won't. So an incredibly clinically biased study, but potentially a very pragmatic and real-world study as well, because that is what we do every day. Yes, we'll put this patient on. No, we won't put that patient on. This is not necessarily for everyone. What did they do? They ensured that everybody had mechanical CPR. They gave everybody 30 mils per kilo of ice cold saline, and then they cooled everyone down. And as you know, the evidence around therapeutic hypothermia is probably looking more towards there's no difference between normothermia versus hypothermia, but we don't really know whether that's true in ECMO or not, because some of the complications with hypothermia were, of course, cardiovascular complications. Everyone went on to percutaneous veno-arterial ECMO placed by intensivists, so no cut-downs, and everybody went off to the cath lab afterwards. And it's likely to be that there is a package of care. If we look at the rest of the ECMO literature, which we're going to look at later this afternoon, ECMO can't be viewed in isolation. It is part of a package of care, and one of the things we need to think about in the cardiac arrest situation is the management of the heart, the management of getting the coronary arteries open, and looking after the rest of the patient, and then all of our post-arrest care. So what did the CHEER study find? Oh, the bottom of the slide's cut off. So what they found was they included 26 patients. So this was very small. It's a small pilot study. They had 11 in the out-of-hospital cardiac arrest and 15 in in-hospital. If we look at the in-hospital group, they had a 60% survival, with all 15 patients going on to ECPR. So this was an uncontrolled group. 9 of those survived. In the out-of-hospital cardiac arrest, however, if we look at what they managed to achieve there, they ended up with about a 45% survival, but once we exclude the patients who survived, who got a ROSC prior to ECMO, who were included in the intention to treat analysis, it was 27%. So a small prospective pilot study. It'll be very interesting to see what they do with the next group. What about the predictors for survival? So if we look at the pre-ECMO information, which is often all you've got is a blood gas and an attempt at an age. You may or may not have any other comorbidities or history for these patients. So we know the lower the bicarb, the more likely you are to die, either during or after ECMO, so prior to hospital discharge. The same, unsurprisingly, is the same is true with lactate. The lower the pH, the lower the pH, the more likely you are to die. The higher the lactate, the more likely you are to die. And of course, these are really composite metabolic indicators for duration. The longer the duration cardiac arrest, the higher the lactate, the lower the pH, the lower the bicarb. And unsurprisingly, duration is strongly correlated with survival. If we look at the specific indicators for neurological outcome, we've got a lower lactate, a higher hemoglobin, which will be the blood oxygen reserves, and a lower time from onset of cardiac arrest to ECMO. So again, we're looking at factors of time. We have to institute this therapy early. This is not something to be thinking about at an hour or 2 hours into the cardiac arrest. This is something to be thinking about at the time or shortly after cardiac arrest. And in fact, if we look at a graph of time versus survival, you can see that most likely ECPR is going to buy you a little bit of time. It might buy you a greater survival for a slightly longer duration of arrest, but it is not a panacea for every patient. This is attempted to be quantified in the ECPR score, and people have looked at the factors that are associated with survival. So younger patients, not surprisingly. VF, do better than anyone else. Short duration CPR to ECMO time. Better pulsatility once you go on. So an initial pulse pressure greater than 24 millimeters of mercury, and not in multiple organ failure afterwards. So clearly if you've gone into hepatic and renal failure, the insult to the body is far greater and is likely to be correlated with a neurological injury as well. In this particular study, they looked at the ECPR score and found that a score of 10 was strongly correlated with survival. So 10 or more. So a younger patient, shorter duration cardiac arrest, not in multiple organ failure, who's maintained a pulsatile circulation. So if we're thinking about how we're going to implement this, we need to start thinking of it as a system of care and moving away from a therapy concept to a system of care. So we've got our indication, we've got cardiac arrest. We need to have some inclusion, and in this particular paper they looked at young patients witnessed arrest, less than 5 minutes of cardiac arrest, of CPR commencing. They contraindicated a large group of patients, low end tidal CO2, asystole, lactates being very high, known comorbidities, the sort of patients you wouldn't offer it to. And if you had those or you didn't fulfill their inclusion criteria, then they offered medical management. If we think of the pathway of care that you would have to implement, you have to start with your cardiac arrest.
5 minutes, please.
Going to CPR, it's refractory. You've then got the option. Do you think about it or not? Do you transfer to an ECPR facility? Do you transfer the ECPR to the patients? These are questions that haven't been answered yet. You need to then consider about moving the patient to the right hospital, commence ECPR, and you have some outcomes. You either have the patient get better, have a good cerebral recovery, or a poor cerebral recovery with ROSC. In which case you do need to think about how you're going to stop, how you're going to withdraw ECMO, how you're going to think about the palliative care for the patient. Because it's very easy to keep someone's body alive on ECMO, not necessarily their brain. And of course, if you don't have return of spontaneous circulation, you still have to think about exactly the same. How are you going to stop the pump in the circumstance where there is no hope of cardiac recovery? The next thing you need to think about is speed. This is not a therapy that you can have a coffee before. You need to have a system in place where you can get there very, 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 very quickly. And whether that's getting the patient to you or getting to the patient, you've got to look at that. You've also got to look at the teamwork. This is not a solo physician acting as a hero. This is a team. Nurses, perfusionists, multiple doctors. A huge number of people need to be involved in order to get this right. You need to be slick. And as we've heard already in the simulation talks this morning, you need to practice. This is not something that you can just turn up and start doing. You need to think about your anatomy. You need to think about how you're going to gain access. I'm an intensivist. I do everything percutaneously. I use ultrasound. But it doesn't always work. It can be very, very difficult. You can, as has happened in this case, and you can see quite nicely the two cannulae clearly in the same vessel. And in fact, if you look at the CT, you can see that the cava is full of contrast on the CT, and the left heart has got nothing in it. So you do need to think about how you're going to get access. Is that going to be your surgical colleagues? Is it going to be percutaneous? Is it going to be in the cath lab? What structure are you going to put in place? We also need to think about our knowledge gaps, because at the moment ECPR is something that can be done. It's technically not overly difficult once you've got somebody who can gain access. But we don't really know whether it's really truly beneficial. We don't really know what we should be doing with the pump, what blood flows, what oxygen levels we should be using in order to protect the brain further. We don't know which groups of patients ideally. We've got an idea: younger patients, early cardiac arrest, previously well. We don't know whether we should be doing this before hospital or after hospital admission. We don't know what the temperature should be, because we know from the TTM trial that probably normothermia is adequate, but we don't know whether that's true in ECMO if we avoid the cardiac side.
2 minutes, please.
So I'd put it to you that we're now in a position that at the end of our algorithm, we need to at least start thinking, we need to be open to the possibility of, at the 10-minute mark or thereabouts, in a select group of patients, thinking about ECPR.